Well, another question which comes up very often is how often can we start ARNI? Should we start it in an acute decompensated heart failure patient right when they are decompensated, or should you wait for their discharge or their first follow-up? Now, this is an important day-to-day question which comes to all physicians, and it's a practical question which comes up nearly in every day in our practice, because heart failure is probably the most common reason for us to admit cardiac patients, and heart failure, as we know, is the end point of all our cardiac diseases. That once a cardiac disease burns out, usually a patient lands up in heart failure, whether it's a myocardial infarct or it's a valvular disease or whether it's a cardiomyopathy. Now, when you have admitted a patient with heart failure, irrespective of the cause, the acute decompensated phase, the first few days when you're giving them diuretics, when they are on inotropes or when they are on vasodilators, is not the time to start ARNI. You have to wait for them to stabilize and start them on ARNI when they meet 4 criteria. What are these 4 criteria? Number 1, their systolic BP should be above 100. Number 2, they should be off inotropes for at least 24 hours. Number 3, they should be on no vasodilators, which is NTG and other vasodilators, for at least 6 hours, and they should not have an increasing requirement of diuretics for 6 hours. Now, these were the criteria which were used in the Pioneer HF trial, which told us that if these 4 criteria were matched and you start the patients on ARNI in this subset when they are in the hospital or even in the ICU, they do much better because the curve starts to split much earlier. Meaning, if you started today versus at the time of discharge, today versus the time of the first follow-up, they start to do well immediately after you initiate the drug. So every day that you can start the medicine and give them the ARNI therapy early gives them that much mortality benefit of repeat hospitalizations, reduced dyspnea and NYHA classes, and therefore it gives you a better outcome mortality wise, and also the patient starts feeling better faster. So this molecule is one of the most landmark life-changing molecules in heart failure patients, and even in acute decompensated heart failure, it should be started when those 4 criteria are met: systolic BP, inotropic requirement, the vasodilator requirement and the diuretic requirement. When these 4 criteria are met, you should start the ARNI therapy.